Good morning, everyone. Nice cold day, and it's going to be like this for the next week. That's what I hear. I've been here like 3 years, so we have the sun and everything, and a change like this once in a while, I like it. So, but coming back to this, before we get into basal ganglia, a question. A patient presents to you, he has various symptoms. He has symptoms of pain and temperature loss in certain parts of the body. I'm not going into details because those are not significant. I'm going to give you one significant finding. He has loss of pain and temperature. He has loss of the sensations carried by the dorsal column tracts. He has spastic hemiplegia. He has all these symptoms. I'm not going into where and which side because they're all distractors. But he also has symptoms of Horner's syndrome. He has symptoms of Horner's syndrome, and where could the possible location of the lesion be? I'll give you options. The ventral pontine fibers, the crus cerebri of the midbrain, the tegmentum of the pons, the tectum of the midbrain, and the tegmentum of the midbrain. There are two correct answers in the options that I gave. Both the tegmentums, tegmentum of the pons, tegmentum of the midbrain, these are the only sites which could cause Horner's syndrome. The crus cerebri, ventral pontine fibers will only contain motor tracts, corticospinal and corticobulbar tracts. If you go back to the tectum, it has gray matter. You will expect the colliculi, or you'll probably expect some of those nuclei, Edinger-Westphal nucleus and structures like that. But it's the tegmentum which contains the reticular formation, the hypothalamospinal tract. If there is a damage to the hypothalamospinal tract in the brainstem, then you can expect Horner's syndrome. So you could have all the symptoms. I've cut down on all those. I could give you a stem which has a long set of symptomatology. He has pain and temperature loss in the face on one side. He has pain and temperature loss in the rest of the body on the same side. He has spastic hemiplegia. And in all these symptoms, the Horner's might be hidden. But it's a key point because that will help you to localize that it has to be the tectum that is affected. If I include the fact that he has spastic hemiplegia, that's probably going to encroach onto the ventral pons and the crus cerebri also. Do you understand this? Based on these symptoms, going back to which parts of the midbrain, one thing that you're familiar already is, based on the symptoms, being able to localize and say this is the tract. If I say spastic hemiplegia, you're already thinking in terms of upper motor neuron, corticospinal tract. Well, in the brainstem, what you have to do is go one step further and say where exactly that corticospinal tract is present in the brainstem. If it is the medulla, it's going to be the pyramid that is involved. If it is the pons, it's going to be the ventral pontine fibers, and if it is the midbrain, it is the crus cerebri. Likewise, if I include Horner's syndrome, that means it's the tegmentum that is involved. Let me move on. We'll study about the basal ganglia. The function of the basal ganglia is coordinated movements, and basal ganglia disorders, if there is any damage to the basal ganglia, degeneration, any lesions of the basal ganglia, can lead to two different sets of symptoms. A person could end up having a hyperkinetic disorder or a hypokinetic disorder. Hypokinetic, where there is paucity of movements, where there is scarcity of movements, slow movements, what is also called as bradykinesia. The other end of the spectrum is hyperkinetic syndrome, where there are involuntary movements even at rest. Involuntary movements at rest, hyperkinetic disorders. The most of the lecture on this basal ganglia, we're going to look at certain interconnections between the basal ganglia. There are two different circuits which have these interconnections. One is called the direct pathway, the other is called the indirect pathway. These two have different effects on the cortex. One has a excitatory effect on the cortex, the other has a inhibitory effect on the cortex. So the point is, if one of them is increased, if the excitatory effect on the cortex is increased, then the person will end up having a hyperkinetic disease. If the inhibitory effect on the cortex is increased, the person will end up having a hypokinetic disease. In normal people, there is a balance between them, so we don't have hyper or hypokineticity. So the bulk of the lecture, the cream of the lecture is those two pathways. The two pathways we will use as a basis to understand hypo and hyperkinetic disorders, right? Let's start with the structures that are included under the heading basal ganglia. Basal meaning at the base of the cerebrum or inside the cerebrum, and ganglia meaning aggregation of cell bodies. Caudate nucleus, we have seen that forming the floor of the lateral ventricle. Putamen and the globus pallidus, which together form the lentiform nucleus. Lentiform nucleus. Other structures are a subthalamic nucleus and a substantia nigra. Substantia nigra, not really within the cerebrum, is part of the midbrain, but functionally it is linked with these other structures, so it is considered as a part of the basal ganglia. Subthalamic nucleus, just from the name, it's a nucleus that is below the thalamus, above the midbrain. Subthalamic nucleus. The rest we have seen: caudate, putamen, globus pallidus. How is the globus pallidus further subdivided? Into an externum and an internum. Globus pallidus externum and globus pallidus internum. This is a schematic picture, and that is the superolateral surface we are seeing here. This is the frontal lobe of cerebrum, temporal lobe of the cerebrum, and it's as if you're looking through the cerebrum. You're looking through the cerebrum going inside. There's a faint line here. You can see how it is turning around. This structure, with its head, body and tail coming all the way down, that is the caudate nucleus. Caudate nucleus with its head, body and tail. And you can see how the caudate nucleus and this other structure with the dotted line, it's as if that has been cut and removed. This other large structure is the putamen. The outer violet or purple colored structure is the putamen, the outer part of the lentiform nucleus. So these both are in contact here. We call that, what do we call that area where they are in contact? Where the globus pallidus and where the lentiform and the caudate nucleus meet. It's called the ventral pallidum or the ventral striatum. That's where you will find the nucleus accumbens. This is the part where both interconnected. On a coronal section, we saw it like a U-shaped structure. If I have caudate nucleus like this and a lentiform like that, there was a U-shaped structure here, which we call it ventral pallidum. It's also called ventral striatum, the same structure where these both meet, caudate and lentiform. Let me put the labels here: caudate, lentiform. So that is caudate and putamen. If you go further inside, these green structures, globus pallidus externum, globus pallidus internum. Do you understand how they are located? What is this pink structure? Going further deep inside the globus pallidus internum, what is this large pink structure? What is medial to the globus pallidus internum? Yes. Thalamus. It's the thalamus. That's the thalamus. I'll put that horizontal section so you can see this again. I will come back to the slides. Look at this. This is a horizontal section or a transverse section across the cerebrum at the level of the interventricular foramen. And you can see the same structures. Caudate nucleus, that's the lentiform nucleus. And you can see how lentiform is subdivided. Can you see this thin white matter, bands of white matter, which is dividing lentiform into three parts. The outermost part we call it putamen, globus pallidus externum, globus pallidus internum. And if you go further inside, this was the pink structure, thalamus. What separates lentiform and thalamus? What is present here? Posterior limb of the internal capsule. Here you will have the anterior limb of internal capsule. This is as if you're looking through the cerebrum, you're getting a whole picture of the entire size, but in the other picture we have taken a section cut like this, so we are seeing different parts of the basal ganglia. So those are names. We have listed the names, we have listed the parts. There are certain subdivisions, groupings of these basal ganglia together. Some nuclei together are given a different name. Let's look at that. One we have seen, putamen, globus pallidus, both externum and internum. All these together is called lentiform nucleus. This we know. Caudate nucleus and putamen, just the lateral part of lentiform. Caudate and putamen are also called as the neostriatum. The newer and striped part of the basal ganglia. The rest of them is called as the paleostriatum. Globus pallidus externum and internum. Is called paleostriatum. The whole of them, caudate and the lentiform together, is called corpus striatum. What does corpus mean? Corpus means body, a striped body. If you go to this picture, not in this one. Let's look at the same structures on this side. This is caudate. This whole structure is the lentiform. Can you see there's a band here that's running across the anterior limb and connecting caudate and putamen? Can you see this band? This is a large prominent band. It's probably the ventral pallidum, but in addition to this, you will also find certain other bands running all across the anterior limb and making the anterior limb look like it has a striped appearance. It makes it look like it is striped, the anterior limb, because of these cross connections between caudate nucleus and lentiform nucleus, and that's why it's called corpus striatum, or the striped body. Caudate nucleus with its head, body and tail, so it's a C-shaped structure. We have seen that. Putamen is the large lateral part of the lentiform nucleus. Ventral striatum, I have said here. In the lab we said ventral pallidum. They are both synonyms. Is the interconnection, U-shaped interconnection, where the caudate nucleus and the putamen are fused. Nucleus accumbens is a part of this ventral striatum. The subdivisions, globus pallidus is divided into external and internal segments by bands of white matter, which are called, medial medullary lamina and the lateral medullary lamina. If you go to the picture, erasing, you can see there's a band of white matter here. This is called the lateral medullary lamina. There's a band here which is called the medial medullary lamina. Medial subdivides the globus pallidus, lateral separates putamen and globus pallidus. And the last one is a relationship with the internal capsule, structures that are medial to internal capsule and structures that are lateral to internal capsule. Internal capsule is a V which is opening laterally, and medial to the internal capsule is caudate nucleus and thalamus. Lateral to internal capsule is the lentiform nucleus. Lentiform nucleus. I've told you about the importance of this kind of a section. This is a section that you can be frequently tested on. This is the one that you can see all the parts of the lentiform and the caudate nucleus. I have another slide labeling all the structures that you will encounter when you have a lateral approach, when you approach into this area from the lateral side. There are some labels that are important, some not very significant. So I'll exclude the not significant parts. It's all on the slide. But the significant parts we have already seen. So I'm not going to add anything. Just because we have this slide, I'm going to show you the structures. Look at that. Insula, extreme external capsule, 2 capsules, and a claustrum. I'll just show you these here. If you start from the lateral approach, structures that you will encounter, the most superficial here, the gray matter, is what we call the insula. If you go inside the insula, can you see that there's a thin gray matter that I've drawn this line on that gray matter. If I have to put an arrow on the gray matter, this is the gray matter. This gray matter is what is called as the claustrum. And on either side of the gray matter we have white. You have white lateral to that claustrum, white medial to the claustrum. So the white matter that is lateral to claustrum, that's exterior to claustrum, is called extreme capsule. The white matter medial to claustrum is called external capsule. I'll just draw this for you to see this. Let me have a lentiform nucleus like that. Lentiform nucleus. The claustrum appears like that. It has certain spiny projections. So here, this area is the external capsule. Area lateral to that is the extreme capsule. Further outer to this, you're going to have the gray matter. We call this the insula. So after the external capsule, the next structure, putamen. After putamen, globus pallidus externum, globus pallidus internum. The separations here, putamen. After the putamen, this line is lateral medullary lamina. This line is medial medullary lamina. What will you find after that? This is called the internal capsule. Look at that. Internal capsule and a external capsule. What are these capsules encapsulating? They are encapsulating the lentiform nucleus. What is the lentiform? Why does it have that name? It has a lens-like shape. Lens-shaped nucleus is called a lentiform nucleus, and that lens has a capsule lateral to it. It's called the external capsule. It has a capsule medial to it. It's called the internal capsule. Internal capsule. Functionally, internal capsule is significant. All these structures, extreme capsule, external capsule, claustrum, we won't go into details of that. Rest of it we'll see. Putamen, external segment, internal capsule. Further medially, if you go here, you'll have a large mass which will be the thalamus. If you go further internal to it, third ventricle. It's just the same thing put in words. All the structures that you see in this picture, I've put in words looking at it from lateral side. But before we go into the actual circuits,
A little bit of an introduction between the structures which give off fibers, structures which are receiving centers. Substantia nigra, considered together with the basal ganglia because of its interconnections and functional significance. It itself is divided into two parts. This is a horizontal section across the midbrain. These are the crus cerebri, cerebral aqueduct, periaqueductal gray. So the crus cerebri is divided, the substantia nigra is divided into a dorsal part and a ventral part. The dorsal part is called substantia nigra pars compacta, the compact part. The ventral part is called pars reticulata. The point is, this reticulata is similar to the internal segment of the globus pallidus. Internal segment of the globus pallidus. Later, when we look at the circuits, we'll see what the role of globus pallidus internum is, and you have to understand that the pars reticulata has a similar function. So receiving stations and output stations. For receiving inputs, caudate nucleus and putamen. For outgoing impulses of the basal ganglia, globus pallidus internum, substantia nigra pars reticulata. We just said they're both similar. Right, where are these inputs coming from? Inputs to the basal ganglia, where do they receive inputs from? They receive inputs from the cerebral cortex, which releases glutamate, substantia nigra pars compacta. Substantia nigra will always contain dopamine. And it says it is excitatory to some neurons and it is inhibitory to other neurons. What determines whether the dopamine is excitatory or inhibitory? The receptors. Dopamine has a D1, D2 receptors, D1 receptors, D2 receptors. One is excitatory, one is inhibitory. We'll look at that. And the last input to basal ganglia from thalamus. There are certain nuclei in the thalamus called the intralaminar nuclei, which also releases glutamate and is excitatory. So three sources of inputs. Outputs. Main output is that internal segment of globus pallidus and pars reticulata of the substantia nigra. Just repeating what is here. These are the two outputs, the same thing. Those are the two outputs. How they are subdivided, what is the role of substantia nigra, what is the role of globus pallidus internum. Substantia nigra carries information about movements of the head and neck. The rest of the body information is carried by globus pallidus internum. They both of these, GPI, globus pallidus internum, pars reticulata, influence the anterior nucleus of the thalamus. I'll speak a little bit about thalamus. Strictly speaking, it's part of the next block, but just for you to understand, when we studied the various ascending tracts, the pain tract, the dorsal column tract, I didn't tell you to really bother about it. I said you can as well as forget it for now. We said all these tracts relate to the ventral posterior nucleus. So the thalamus is a large mass of gray matter, and it has various nuclei within the thalamus. And certain nuclei have specific functions, certain nuclei have regulatory functions. And the ventral posterior nucleus is sensory. It receives all sensations from all parts of the body. This anterior nucleus of the thalamus influences the area 4. It helps in coordinating movements. Anterior nucleus of thalamus relates to area 4. When we study the thalamus itself, we'll list out all the nuclei and we'll try to assign functions for them. And the neurotransmitter here, it's GABA. Here meaning the neurotransmitter that connects globus pallidus internum to this ventral anterior nucleus. There you have GABA. All this is just introduction. When we get to the actual pathway, you will see how all this fits together. That's what this is. Thalamic neurons influence premotor, supplementary motor, primary motor areas. So coming to that crucial part, the intrinsic connections of the basal ganglia. Two connections or two pathways, a direct pathway and an indirect pathway. This is the direct pathway, which it's here. I'll draw a picture for you to understand this part. Direct pathway. It begins in the cerebral cortex and it relays into the striatum. What does striatum mean? Which are the nuclei included under striatum? Caudate nucleus and putamen, and from there it goes to globus pallidus internum. Let me draw the picture. This picture is not on the slides. I'm drawing it. It's in words in the slides. You will understand when I draw the picture. So if you want to copy it, you should. Right, I've drawn these on one side. My picture hasn't been very proportionate. If this is the midline, it's gone across like that. The same three structures you will expect on the opposite side also. So let me just draw this on this side just for labeling them. Caudate nucleus, lentiform nucleus, and the thalamus. Above, it's a coronal section across the cerebrum. Look how I have drawn the thalamus. Its anterior end is narrow and posterior end is rounded. I've drawn that. Within the thalamus there is a Y-shaped white matter dividing it into many parts. We won't go into all those details, but this is the nucleus. We call it the ventral anterior nucleus. Ventral anterior nucleus, that's the one we said will project to the cortex. Here I have divided lentiform into the globus pallidus internum, externum, and a putamen. So I'll now show you the circuit. Begins in the cerebral cortex. So cell bodies are here. They come down and project to the putamen. The same fibers also project to the caudate nucleus. So in some pictures I might not show caudate nucleus, but what you have to understand is neurons beginning here will project to both caudate and to putamen, and efferents from there will also be similar. So it's a direct pathway. I'll tell you why it is called direct, because the putamen fibers, neurons from the putamen project directly to the globus pallidus internum. They bypass the externum, go directly to the internum, and then from that internum, new set of neurons to the ventral anterior nucleus, and then from the ventral anterior nucleus, fibers coming back to the cortex. Fibers coming back to the cortex, just where it began from. So that's the circuit. Let me just add the neurotransmitters involved here. This is glutamate from cortex to putamen and caudate nucleus. From putamen caudate nucleus to internum, it's an inhibitory neurotransmitter, GABA. From internum to ventral anterior is also GABA. And the last one going back to the cortex is glutamate. Look at this, the same thing here. Cortex to striatum, glutamate, striatum to globus pallidus internum, GABA, globus pallidus internum to the ventral anterior nucleus of the thalamus, releasing GABA, and from the thalamus to the cortex, glutamate. If I have to name the neurotransmitters in sequential order, glutamate, GABA, GABA, glutamate. End result on the cortex, net effect is excitatory to the cortex. Let's see why it is excitatory to the cortex. I'll first tell you the simpler way of looking at it, then we'll go into the detailed way of looking at it. Glutamate is positive, GABA is negative, that is negative, and the glutamate again is positive. Just using the basic principles of algebra, positive into positive is equal to positive, positive into negative is equal to a negative sign, negative into positive is also equal to negative, and then negative into negative is positive. So you use the same formula, you'll see what happens. Glutamate is positive, so that's a positive into negative here when it comes here. So we have negative at this point, then it is negative into negative, which turns positive, and this positive into positive, net result positive on the cortex. This is a simple way, but if you want to look at the basis, why it is positive, why it is negative. Neurons here fire and they release action potentials. They release glutamate at this point, they release glutamate. What will glutamate do? When glutamate is released, what will it do to the next neuron, to the neurons of the putamen? Will it cause depolarization or hyperpolarization? It causes depolarization. If depolarization is caused here, action potentials are again generated. What will happen at this terminal? What will these neurons do? Will they release more GABA or less GABA? Because of depolarization, these neurons are excited, they will release lots of GABA. They will release lots of GABA. And if lots of GABA is released here, what will its effect be on the next neuron? Will there be depolarization or will there be hyperpolarization, considering that GABA is an inhibitory neurotransmitter? Hyperpolarization. And if this neuron undergoes hyperpolarization, what will it do at its terminal? Will it release GABA or not release GABA? It will not release GABA. If GABA is not released, the thalamic neurons will go into their inherent rhythm where they will just constantly keep getting excited and releasing glutamate. They'll keep getting excited, releasing glutamate, and if glutamate gets to the cortex, it has an excitatory effect or a depolarizing effect on the cortex. Yes, excitatory neurotransmitter causes depolarization. Any questions about this so far? Yes? Yes. I didn't mention that. Not just area 4, premotor, supplementary motor, all motor areas. Motor coordination, we take it for granted because it's not a conscious effort, but there's a lot of inputs coming together to have that end result of smooth movements. Any questions about the pathway? No? So I'll just one small addition to this. That's the pathway. The addition does not make a difference to it. the striatal neurons that project to the internal segment of globus pallidus contain GABA as neurotransmitter and substance P. So if I have to add this here, at this point, with GABA, there is also substance P. Substance P. From where, are you talking about this one, the globus pallidus internal? This one, yeah, thalamus to the cortex. The concept of interneurons itself, interneuron is something that is happening in the spinal cord. Those are neurons connecting other neurons. Here, this is a circuit. If you use interneuron, probably every other neuron is an interneuron, beginning from the first one here and the last one here. Everything in between is an interneuron, but we don't use that term here. Let me ask you this. Yeah, these are neurons beginning in the cortex. I said they project to the putamen and to the caudate nucleus. I have continued the circuit from caudate, but what happens here? If these neurons are relaying here, what will the next neurons do? These neurons will act just like the neurons of the putamen, so they will just come here and project here. I don't draw this to keep the image simpler. The same thing happens there also. Caudate and putamen act together. Just like globus pallidus internum and that substantia nigra pars reticulata.
Were originally aren't they hyperpolarizing? Now if they're coming from the caudate nucleus, aren't they stimulatory?
No, see, there's no change in the neurotransmitters. Still the same thing. You'll have GABA here. You'll have GABA here. So if you begin from the cortex, glutamate is coming to caudate nucleus, it's going to depolarize the neurons of the caudate. So caudate nucleus here, these neurons are going to be excited. They're going to release lots of GABA at this point. And when they release GABA, they are going to hyperpolarize the globus pallidus internum. That means lesser GABA will be getting to the thalamus. Functionally, no difference. Just for simplification, on the picture, we sometimes exclude this part. I want to start with the indirect pathway. Let me just draw it. We have like 5 minutes. I'll draw that and then we'll go for the break. I'm using another color now. Let me take green. When we go into that indirect pathway, certain things remain same. The original beginning from the cortex, the last part from the ventral anterior going back to the cortex, all that remains the same. The difference lies in the region of the basal ganglia in the lentiform nucleus. So can I do it on the opposite side? Yeah, that's probably better. I'll do it on this side. So neurons in the cortex, they begin from there, they run down to the putamen. Same thing would be happening even in the caudate nucleus. And then from this putamen, because it's now the indirect pathway, it can't go directly to internum, it ends up in the externum. It ends in the externum. From the externum, it comes out to the subthalamic nucleus. Subthalamic nucleus. And then from the subthalamic nucleus, it goes back to the internum, and then the rest continues from internum to the ventral anterior nucleus, from ventral anterior nucleus back to the cerebral cortex. Is my picture too shabby for you to understand? Do you want me to redraw or is it good? Redraw, not clear? Clear or not? No? I'll draw both the direct and indirect on the same side. I won't have labels now, so that it remains a little clear, the picture remains clear. Cerebral cortex, caudate nucleus. I'm drawing the lentiform large just for me to have space to draw all these arrows. In reality, it's much smaller. I'm not drawing a large thalamus. Again, for simplification, it's a smaller thalamus. In reality, it's much bigger. That's the ventral anterior nucleus. Right, in red color, I'll mark the direct pathway first. From the cortex to the putamen, from the putamen directly to the globus pallidus internum, from internum to the ventral anterior nucleus, from ventral anterior going back to the cortex. Right? I'll only draw the changes. I'll leave the rest the same because that's a common pathway. Just the changes, and I'll mark it in green. So this part is the same. It begins here. It comes down to the putamen. The indirect pathway begins from these neurons in the putamen, projects to the globus pallidus externum. From externum comes down here to the subthalamic nucleus. From subthalamic nucleus it comes back to globus pallidus internum, internum to ventral anterior back to cortex. Let me add the neurotransmitters now. Red color, first you have glutamate. At this site we have GABA, again GABA, and last part glutamate. The same thing here, it's GABA, GABA, glutamate. I'll show you on the slide. We'll look at this. This is the indirect pathway. Begins from the cortex, projects to the striatum just like direct pathway, but from striatum it can't go directly to internum, it goes to the globus pallidus externum. From the globus pallidus externum to the subthalamic nucleus, and subthalamic nucleus to globus pallidus internum. If you go back to the picture, the whole difference is for these putamenergic neurons, for the neurons of the putamen to project to the internum in the direct pathway, they directly go there. For in the indirect pathway, they go through the externum, subthalamic nucleus and come back to internum. That's the only difference. So let's do the net result on the cortex for the indirect pathway. So this is glutamate, it's positive. Let's do it's causing depolarization here. Because glutamate is released, it's causing depolarization of the putamenergic neurons. The neurons here, because they are depolarized, will release lots of GABA into the globus pallidus externum. The externum neurons responding to the GABA will be, because it is inhibitory, will undergo hyperpolarization. If this is hyperpolarized, there is not enough GABA released at the subthalamic nucleus. If not enough GABA is released, subthalamic nucleus is free to release as much glutamate into the globus pallidus internum. Because glutamate is released here, it's going to activate the globus pallidus internum, it's going to depolarize the neurons here, and in response to depolarization, it's going to release lots of GABA in the ventral anterior nucleus. When GABA acts on the ventral anterior nucleus, it is inhibitory, it causes hyperpolarization, thereby the amount of glutamate released in the cortex is decreased, and if there is decreased glutamate in the cortex, it is inhibitory. So that's the difference between direct indirect pathway. Direct pathway is excitatory, the indirect pathway is inhibitory to the cortex. You have any questions, or you want to save the questions for after the break? Yeah? Yes? Can you be a little louder? Yes, the last step for both pathways is glutamate. It's a common step. Because there is less of it. Because there is less of it. Yeah, in the indirect pathway, why is it inhibitory? That's the question you're asking. See, from here, lots of glutamate is released to make the globus pallidus internum depolarized. In response to depolarization, these neurons release lots of GABA. The GABA, when it acts on the ventral anterior nucleus, ventral anterior becomes hyperpolarized. Hyperpolarized, yes. Hyperpolarization causes ventral anterior to be less active, thereby releasing less glutamate to the cortex. Now, if you look at the direct pathway, from the putamen you have GABA coming to the globus pallidus internum. GABA, when it comes to globus pallidus internum, it's going to hyperpolarize globus pallidus internum. So in response to that, less GABA will be released. And when less GABA is released, the thalamus is free to act, is going to release more glutamate. All the difference, you raised a good point. This is the link. No, it's too light. This area, the difference lies here. In the direct pathway, what is coming in, the incoming impulses to the globus pallidus internum, are they inhibitory or are they excitatory? In the direct pathway, because it is GABA coming in, it is inhibitory. If it's inhibitory, it's going to cause depolarization. That means less GABA is released to ventral anterior nucleus in the direct pathway. In the indirect pathway, the impulses coming in, these green impulses coming into the internum is glutamate. It's excitatory, meaning it's going to make the globus pallidus internum work harder, release more neurotransmitter. And if it releases more GABA, it's going to inhibit the ventral anterior nucleus. In the absence of GABA, ventral anterior is free to act. Right, let's take the break, come back in 10 minutes.
correct, the schematic.
Cortex to striatum, striatum to internal anterior cortex. Goes for external cerebellum, nucleus, internal cortex. Correct. Yeah. You added this to
Okay, and so what you were talking about, the reason it's excitatory and inhibitory is because the inhibition of an inhibition is a positive.
So guys, are you clear about these pathways? Do you have any questions about this? No? So we'll add on to this. We'll bring in the dopamine because we will start to understand Parkinson's first. So I'll bring in dopamine to these pathways and see how dopamine affects these pathways. So if I have substantia nigra, midbrain, so we have substantia nigra, and from there dopaminergic fibers. They affect both the direct and the indirect pathway. They have different actions on the direct, different action on the indirect pathway. Why? Because the neurons of the direct pathway have the D1 receptors, and the neurons of the indirect pathway have the D2 receptors. The D1 are excitatory, D2 are inhibitory. D1 receptors are excitatory, D2 receptors are inhibitory. What's the net effect of the direct pathway on the cortex? Excitatory. So if you're adding excitation to that excitatory pathway, net result will be increased excitation. Do you agree? Direct pathway is excitatory and you are exciting the direct pathway through the D1 receptors. Net result, excitation. What's the net effect of the indirect pathway on the cortex? Inhibition, and we are inhibiting that inhibition. We are inhibiting that inhibition further by the D2 receptors. So by inhibiting the inhibition, net effect is excitatory. So what dopamine does is increasing the excitation on the cortex through both the direct and the indirect pathways. Do you understand this? It excites the direct pathway, increasing excitation. It inhibits the indirect pathway, decreasing inhibition. Net result on the cortex, increased excitation all over by the dopaminergic fibers. Dopamine from the substantia nigra is causing an excitatory effect on the cortex. Yes. I'll speak about this. See, somebody asked me during the break, we said glutamate, which is a common neurotransmitter in both the direct and indirect pathways. I'm saying indirect is inhibitory on the cortex. It's still glutamate, so why is it inhibitory? It's all a relative phenomena. When there is more glutamate, it is excitatory. When there is less glutamate, it is inhibitory. Similarly, the role of GABA. We talk of GABA being inhibitory, but what if GABA is absent? If GABA is absent, the neurons have their inherent rhythm, they will still keep firing action potentials. The GABA only decreases the amount of action potentials being fired. If you look at this pathway, let's see, including the dopamine now. Glutamate is coming down, it is exciting these neurons. Let's look at this indirect pathway. The neurons of the putamen are being depolarized by the glutamate. By depolarization, more GABA was supposed to be released here. Increased GABA was supposed to be released. But once you bring in the effect of the D2, the dopamine through the D2 fibers, it is inhibiting these neurons already. So it's the depolarization of the cortex and the hyperpolarization of the dopamine together. Net result is a decreased amount of GABA being released here. If decreased amounts of GABA, meaning these neurons are not as inhibited as they originally were, so little bits of GABA is still getting here. That's why the net result becomes excitatory on the cortex. If less GABA is coming here, if there is decreased inhibition, so there's more GABA coming here. If more GABA comes here, less glutamate will be released. If less glutamate is released, that means what happens here? The GABA released will be decreased. If GABA release is decreased, ventral anterior can fire more glutamate. That's the whole idea here. The dopamine through both the direct and the indirect pathway causes a net excitation of the cortex. So let's look at Parkinson's disease. Parkinson's disease, the main lesion is the decreased amount of dopamine in the substantia nigra. Substantia nigra, as you've seen even on the specimens in the lab, it appears dark in color. And if you look at the midbrains of patients who had Parkinson's on autopsy, you'll see that the substantia nigra appears very pale. You don't see the dark color, you're not able to clearly differentiate that. So that's because of decreased dopamine. And what happens if there is decreased dopamine? The dopamine was supposed to have an excitatory effect on the cortex. Now in the absence of dopamine, the net effect on the cortex is inhibitory. If it is inhibitory, what will happen? You will have the hypokinetic symptoms. Hypokinetic symptoms. Do you understand this? Silence is acceptance. So I'm seeing silence and I'm going forth. Yeah. Yeah. Just one point that I missed. We said co-transmitters for this part, for the direct pathway. We said GABA and the substance P. Similarly, for the indirect pathway, you have GABA here. It's GABA and enkephalin. Enkephalin. The striatal neurons to the external segment contain enkephalin. Enkephalin and externum both starting with an E. That's like a mnemonic there. They are in the putamen, like I've shown in the picture. They will also be here in the caudate because this same thing continues here. Remember what we said? So they will be in the putamen and in the caudate nucleus.
Is this the same receptor as the pain opioid receptor? The opioid receptor?
Enkephalin is a neurotransmitter, and yes, you will expect the same enkephalin in those neurons also, but this is not linked to that. It's the same neurotransmitter, that's all.
Does that mean to do with negative or positive?
No. This has nothing to do with sensations. That's a pain sensation. This is a motor tract, a regulation of movements. You can't link this with that. The only similarity between these two is the same neurotransmitter. Hypokinetic disorder. Yes.
These two double neurotransmitters are only supposed to be inhibitory effect, right? Such as P will have an inhibitory effect as well.
Enkephalin also having an inhibitory effect. I heard the pathway until caudate nucleus. The caudate nucleus and the putamen have the same function, be it direct pathway, be it indirect pathway. If it is the indirect pathway, you're talking about the neurons from the cortex relay in both caudate and putamen. What does the putamen do? The putamen sends impulses to the globus pallidus externum. So the same thing here. From here, it will relay into the globus pallidus externum, and then from externum, the same pathway continues. Caudate and putamen have exact same functions. Yes, that's the question he asked. They will also have the D1, D2 receptors, the same thing. These fibers from the substantia nigra will also relay in the caudate nucleus. Right, so just introduction into these features of basal ganglia disorders. It's common, both the excitatory and inhibitory effects. Tremors at rest. I'm sure you know what is a tremor, that the shaky movements. Tremor at rest is a feature of basal ganglia disorders. There's another kind of tremor, it's called intentional tremor. What's the difference between tremor at rest and an intentional tremor? Intentional tremors occur while performing an action. Supposing you ask the person to reach for this. As his hand gets closer, when he is trying to reach for it, as his hand gets closer to the object, then you see certain tremors. Those are intentional tremors. The person is intending to perform a movement, perform an action, and the tremors become obvious then. Tremor at rest with no movements, even if he is sitting down, he still has tremors. Intentional tremor is a cerebellar symptom. Tremor at rest is a basal ganglia symptom. Dyskinesia, meaning abnormal movements, abnormal involuntary movements. Chorea and athetosis, two different components. In some conditions, there is a combination of the both. We call it choreo-athetoid movements. What is chorea? What type of movements are called chorea? Dancing type of movements, non-repetitive movements. Athetosis is writhing movements, like a snake, writhing movements. I have videos for this. Let's look at this. Short clips. So those are the writhing movements.
Yeah, okay. Put me there, Tawa. Ja, je merkt wel dat je dit doet? Dat je nu helemaal weg bent.
Yeah, that's what it is. So you can imagine those are movements that the boy is doing not due to any, he doesn't want to perform any movements, he's just lying in bed and these movements are happening. So you can imagine how disabling it will be to the person who has these kind of movements at rest. If he wants to perform an action, you can imagine how difficult it's going to be with all those involuntary movements going on. movements of the neck. Possible, yes. Yes. So, strictly speaking, if you look at the boy's movements, he had a little bit of the writhing component also. It's a chorioathetoid movement. Chorioathetosis, you might not expect pure chorea or pure athetosis. Patients may present with a combination of the two. The next point, significant one in terms of multiple choice questions. Movement disorder is on the contralateral side to that of the lesion. Meaning if you have a lesion in the right-sided basal ganglia, the movement disorder will be on the opposite left side. I've shown you the pathway. Why do you think it is on the contralateral side that the patient is presenting with symptoms on? Because it goes back to this motor area, area 4, and this motor area 4 is going to then regulate the opposite contralateral half of the body. So all symptoms of basal ganglia, contralateral.
That video, I mean, he was moving his whole body, so that's in both.
He has bilateral.
Literally just see one side of the body moving.
Parkinson's begins one side and then progresses to next side. He did not specifically have Parkinson's, but I'm just telling. Gait is affected. I mean, just like involuntary movements, gait will be affected. These are the two ends of the spectrum. Bradykinesia, hypokinesia, akinesia, all going together hand in hand, hypokinetic disorders. Brady meaning slowed movements, hypokinesia, decreased amount of movements. This is a severe condition where there is akinesia, total absence of movements. All these are the hypokinetic set. The other end is hyperkinetic disorders, increased amount of movements. Chorea, athetosis, all features of hypo or hyperkinetic. Are they features of hypokinetic or hyperkinetic movements? Hyperkinetic, look at this. Hypokinesia by definition, decreased amount of movements. So even the movements that are required will be less. And these are movements that are not required. It's a feature of a hyperkinetic disorder. Hyperkinetic disorder. These are hypokinetic disorders. Parkinson's is a hypokinetic, Huntington's is a hyperkinetic. So bradykinesia, hypokinesia, important features of Parkinson's. There is also rigidity, which is defined as increased resistance to passive movements. What's another word for this? Increased resistance to passive movements. Tone and hypertonia. Hypertonia is also called rigidity. But there's a difference between the hypertonia or spasticity of the upper motor neuron and the rigidity that you expect in basal ganglia disorders. The rigidity here is called as a lead pipe rigidity or a cogwheel rigidity. Two different phenomena, but both are related to basal ganglia lesions. What is lead pipe rigidity? It's as if you're trying to bend a bar of lead. So if you're trying to flex it and bend it into two pieces like that, you will feel uniform resistance throughout the movement. When it is flat like this to the point when it is entirely bent like this, you'll find uniform resistance throughout the movement. Just like that for the limb. If you're flexing the elbow, you'll find resistance, you'll encounter resistance throughout the movement. The other one is called cogwheel rigidity. Here it happens in jerks, as if there is a cog that comes every now and then. So you find resistance, then there's a give, you find resistance, then there's a give. So that's a cogwheel rigidity. How are these? These are both for basal ganglia. What kind of rigidity will you expect in the spasticity of the upper motor neurons? And this is called a clasp knife rigidity for the upper motor neuron lesion. How does a clasp knife work? You will find resistance initially when you're trying to initiate the movement, and then there's a sudden give. Like the knife, which is you open the knife or you're putting the knife back. when you pull the knife out, initially you find resistance, then it just slips out. Or when you're closing it in, initially you have to bend it, and then it just goes back into its slot. So that's a clasp knife rigidity for upper motor neuron, a lead pipe or a cogwheel rigidity for a basal ganglia. All disorders that have bradykinesia, hypokinetic disorders, will present with rigidity, meaning Parkinson's, the person will have rigidity. The heading is not very appropriate, it's only the hypokinetic that's here. In Parkinson's, in Parkinson's disease, dopamine containing neurons of the substantia nigra have degenerated. Dopamine had a net excitation on the cortex because it's excitatory to direct, inhibitory to the indirect, just what we saw in the pathways. And if there is loss of dopamine, it results in inhibition of the thalamus, leading to inhibition of the cortex. So drugs that can enhance the dopamine transmission can relieve symptoms of Parkinson's. We'll look at the drugs a little later. This is that same pathway, it's in a different format. You can see how this is the cerebral cortex. One side it's the direct, one side is the indirect. Let's look at that. It projects to the putamen and caudate nucleus, both of them, and from there, this is the indirect pathway because it goes to externum. This is the direct pathway going directly to internum. You can see how from externum through the subthalamic comes back to internum. Rest of it is same. Internum to thalamus, ventral anterior, ventral lateral nucleus to the frontal cortex. And how substantia nigra, which is secreting dopamine, has different actions. One is D1 for the direct pathway, D2 for the indirect pathway. D2 is inhibitory, D1 is excitatory. So the various drugs used for treating Parkinson's disease: anticholinergic drugs. Anticholinergic drugs are one group that help in relieving the symptoms of Parkinson's. How are these drugs effective? The neurons of the striatum, let's go back to the picture and I'll show you this. The neurons in this striatum, meaning in the caudate nucleus and in the putamen, these neurons contain, guys, you are distracting me. These neurons contain acetylcholine, and this acetylcholine is inhibitory to the neurons here, both in the direct indirect pathways. Acetylcholine preferentially excites the indirect pathway. It excites the indirect pathway. So if I go back to the picture, the acetylcholine acts specifically on this indirect pathway, and it stimulates the indirect pathway. Remember, indirect pathway has a net inhibition, and if you stimulate the indirect pathway, it's going to cause net increase in the inhibition. So acetylcholine is inhibitory to the cortex. If you use anticholinergic drugs, you're going to decrease the inhibition on the cortex, and that's what we want in Parkinson's disease. All these drugs used in Parkinson's, the basis of their treatment is all very important key features, what do you call, high yield areas. Acetylcholine preferentially excites the indirect pathway. Anticholinergic drugs will break down acetylcholine, thereby this excitation of indirect pathway is removed. We spoke so much about Parkinson's, just summarizing all those clinical features together. The lesion is loss of dopaminergic neurons in the substantia nigra. So substantia nigra is much paler in sections. You can notice the paleness even on a MRI. Also the presence of Levy bodies, inclusion bodies. Symptoms: resting tremor, tremors at rest, also a term used in relation to the symptoms of Parkinson's is called as a pill rolling movements. It's as if the person is rolling a pill between his thumb and index finger. Pill rolling movements. Bradykinesia, slow movements. Rigidity of the cogwheel and lead pipe type of rigidity. And a specific gait, it's called Parkinson's gait with festinations. Let's look at that. Oops, it's not the video here. I think the festination, yes.
This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this, and as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again having difficulty starting in the marche petit pas.
Why is that turning like that? Why does the person have to turn en bloc? What is contributing to that? The lead pipe rigidity. So initiating movements, like you said, when beginning to walk, initiating movements becomes difficult because of all this rigidity. Festinations is that sudden quickening after they picked up, after they started walking. To initiate movements they had difficulty. Once the person started walking, he picks up speed. The other picture was actually, it's from Wikipedia. It's a picture. It shows you that stooped posture, stooping forwards, and the tremors, the pill rolling movement. You can see how the thumb and the index finger are related like that. So it begins as a unilateral condition and can progress to become bilateral. All these symptoms, and the person has a mask-like face. There's no expressions on the face. Person does not seem to be interested in the surroundings. All that is what is called as flat effect and reduced spontaneity. Person is not interested, appears as if he is not interested in surroundings. No facial expressions, what is called as a mask-like face. It is because of the mesocortical pathway. The mesocortical pathway is also dopaminergic, begins from the midbrain region and projects to the cortex. Decreased dopamine in that pathway contributes to this kind of effects, flat effect and reduced spontaneity. Like, this is a key slide, treatment options, the basis of each drug that is used. One that is missing is the anticholinergic drugs. We already spoke about that. Anticholinergic. What's the effect of, why do we use monoamino oxidase inhibitors? Decrease the breakdown of dopamine, so you're making most out of the little bit of dopamine that is present. The dopamine supplements, you use a dopamine precursor, levodopa or L-dopa, because dopamine itself can't cross the blood-brain barrier. And most often levodopa is tagged or is combined with another drug called carbidopa. It's a dopa decarboxylase inhibitor. What does this do, dopa decarboxylase? Conversion of levodopa to dopa. Dopamine, I mean, when I say dopa. Levodopa is converted to dopamine, and that's the enzyme that is involved there. So it inhibits the formation of dopamine in the peripheral tissues before it crosses the blood-brain barrier. We want that conversion to happen after it crosses the blood-brain barrier. If levodopa is converted to dopamine before crossing the blood-brain barrier, there's no point using levodopa. We are using levodopa because it can cross the blood-brain barrier. And if it's broken down before the crossing, there's no point. So they're used together, carbidopa and levodopa. I've explained anticholinergic drugs, MAO inhibitors, which prevent the breakdown of dopamine. The rest, transplantation of embryonic tissue with the hope that, yes.
Carbidopa not entering the CNS, so it won't have the same effect there?
Yes, it will not cross the CNS, so it won't have the same effect. Correct, you're right. Transplantation of embryonic tissue with the hope that it will develop into that dopaminergic neurons and secrete dopamine. And stereotactic lesion of the globus pallidus, meaning you are inducing damage to the globus pallidus. How will that help? How will damaging the globus pallidus help? You have to go back to the picture. Exactly. This internum segment is the one that is inhibiting the ventral anterior nucleus. So if you damage this, if you cut off this inhibition, the ventral anterior nucleus is released from inhibition, so it can release glutamate and cause excitation in the cortex, relieving symptoms in Parkinson's. But that's about Parkinson's disease. We'll look at this last slide before we call it a day. The next one is called hemibellismus. Bellismus is derived from the same ballistic. There is violent flinging movements in one half of the body, so it's called hemibellismus. Violent flinging movements, unilateral, it says wild flinging movements, really force, a lot of force in those movements, flinging movements. It's due to damage of the subthalamic nucleus. And the contralateral is just the same for all basal ganglia. So if you have a right subthalamic nucleus damage, the person will have a left-sided hemibellismus. This again, is frequently tested, hemibellismus. Injury to the subthalamic causes decreased excitation. All that's the same thing. If you go back to the pathway, subthalamic nucleus, what is its role? It releases glutamate, it stimulates the globus pallidus internum to release more GABA and inhibit the ventral anterior nucleus. So if this is lost, if the glutamate from subthalamic nucleus is lost, what will be the net result on the cortex? Is it a hyperkinetic condition or is it a hypokinetic condition? Hyperkinetic. The inhibition from globus pallidus internum will be reduced. If glutamate from subthalamic nucleus is not coming into internum will not release as much GABA. If not as much GABA is released, net effect hyperkinetism. It will stop here, and we'll probably do Huntington's tomorrow.